Antimicrobial stewardship protects patients. It also protects antibiotics. Antimicrobial resistance grows or increases when antimicrobials are misused. Large hospitals amplify this risk. 2,000 beds mean thousands of antibiotic orders daily. Every prescription becomes a clinical decision point. AMS teams create safety checkpoints. Clinical pharmacists lead many of these reviews. The goal is not restriction. The goal is optimization. Right drug, right dose, right duration, right patient, right time. This process improves outcomes. It reduces toxicity. It lowers resistance pressure. It reduces cost without reducing care quality. AMS is collaborative medicine. No discipline works alone. Pharmacists work with ID physicians. They work with microbiologists. They work with intensivists. They work with frontline prescribers. This review process is systematic. It is structured. It is reproducible across institutions. AMS programs require leadership support. Administrative backing is essential. AMS teams are multidisciplinary. Infectious diseases physicians provide clinical oversight. Clinical pharmacists perform daily operational reviews. Microbiologists provide organism intelligence. Data analysts provide usage metrics. Infection prevention teams provide epidemiology context. Information technology enables data extraction. Daily workflow must be standardized. High-volume centers need prioritization systems. Not every order can be reviewed immediately. Risk stratification becomes essential. ICU patients receive priority review. Broad-spectrum antibiotic use triggers alerts. Restricted antimicrobials trigger automatic review. Positive cultures generate review flags. Rapid diagnostics accelerate decision-making. AMS meetings should occur daily or several times weekly. Recommendations are documented clearly. Prescription review starts with patient identification. Electronic dashboards are commonly used. Pharmacists review new antibiotic starts daily. They review therapy beyond 48 to 72 hours. They review prolonged therapy durations. Carbapenem use triggers alerts. Anti-MRSA agents trigger alerts. Antifungal therapy often requires review. ICU admissions receive early review. Positive blood cultures receive immediate attention. Patients with renal dysfunction are flagged. Patients with multiple antibiotics are prioritized. De-escalation opportunities are actively sought. Escalation needs are also considered. We will now focus on verifying the indication. The first question is simple. Why was the antibiotic started? Is there a documented infection? Is this treatment or prophylaxis? Is this empiric therapy? Is this targeted therapy? Documentation must be clear. Unclear indications require clarification. Pharmacists contact prescribers early. Diagnostic uncertainty is common. Not all fever is infection. Not all leukocytosis requires antibiotics. Source identification is critical. Pneumonia differs from urinary infection. Intra-abdominal infection differs from bacteremia. Source determines drug selection. We will now progress to assessing patient factors. Every antimicrobial decision is patient-specific. Age influences pharmacokinetics. Weight influences dosing. Obesity changes drug distribution. Renal function must be assessed daily. Hepatic function may affect metabolism. Critical illness alters drug clearance. Augmented renal clearance occurs in ICU patients. Hypoalbuminemia affects protein binding. Immunosuppression changes risk profiles. Allergies must be verified carefully. Many reported allergies are inaccurate. Pharmacists assess reaction history. Cross-reactivity risk is evaluated. Drug interactions are reviewed. We will now briefly consider microbiology review. Microbiology drives optimization. Culture results must be reviewed daily. Gram stain provides early clues. Rapid diagnostic testing accelerates therapy adjustment. Susceptibility data guide narrowing therapy. Colonization must be distinguished from infection. Contaminants must be recognized early. Blood culture interpretation requires experience. Local antibiograms inform empiric choice. Resistance patterns vary by hospital unit. ICU organisms differ from ward organisms. Microbiologists and pharmacists communicate closely. Organism identification triggers reassessment. Let's now discuss evaluating drug selection. Is the chosen drug appropriate? Does it cover the suspected organism? Is coverage unnecessarily broad? Can therapy be narrowed safely? Combination therapy is reassessed. Duplicate coverage is discontinued. Spectrum minimization reduces resistance pressure. Tissue penetration is considered. CNS infections require special selection. Bone infections require prolonged exposure. Pulmonary penetration varies by agent. Pharmacodynamics guide decisions. Time-dependent drugs require exposure optimization. Concentration-dependent drugs require peak optimization. We will now switch gears to dose optimization. Dose optimization is a core pharmacist role. Standard doses may be inappropriate in ICU patients. Renal dosing is reassessed daily. Continuous renal replacement therapy alters clearance. Intermittent hemodialysis requires timing adjustments. Obesity may require higher doses. Subtherapeutic dosing promotes resistance. Toxic dosing increases harm. Extended infusions improve beta-lactam exposure. Therapeutic drug monitoring is used when available. Vancomycin dosing uses exposure targets. Aminoglycosides require monitoring. Antifungals may require level monitoring. Next, we will look at a route of administration review. Intravenous therapy is not always necessary. Early IV to oral conversion is encouraged. Oral therapy reduces complications. It reduces line infections. It reduces hospital stay length. Bioavailability must be assessed. Clinical stability is required before switching. Gastrointestinal absorption must be adequate. Source control must be achieved. We will now progress to duration optimization. Prolonged duration of therapy is a common challenge. Many infections require shorter courses. Evidence supports shorter therapy in many conditions. Automatic stop dates are recommended. Review occurs at 48 to 72 hours. Clinical response guides duration of therapy. Biomarkers may assist in making therapeutic decisions. Unnecessary prolonged therapy increases resistance risk. Clear end dates improve compliance. We will now briefly focus on communication with clinical teams. Stewardship is collaborative. Recommendations must be respectful. Education accompanies intervention. Pharmacists explain rationale clearly. Face-to-face discussion improves acceptance. ICU rounds are ideal opportunities. Documentation must be concise. Recommendations must be actionable. Feedback loops improve trust. Acceptance rates improve over time. And now let's talk about documentation and data collection. Every intervention is recorded. Documentation supports program evaluation. Metrics include days of therapy. Defined daily doses are tracked. Acceptance rates are measured. Clinical outcomes are monitored. Resistance trends are analyzed. Data supports hospital leadership engagement. Reporting aligns with international standards. Guidance may align with World Health Organization recommendations. Practice frameworks may reference Infectious Diseases Society of America guidance. Let's now briefly look at special situations in large hospitals. ICU stewardship requires rapid decisions. Sepsis requires early broad therapy. De-escalation follows stabilization. Transplant patients require individualized approaches. Oncology patients require risk-based decisions. MDRO infections require multidisciplinary discussion. Outbreak situations require rapid coordination. Novel resistance mechanisms require expert review. We will now progress to quality improvement and education. AMS is continuous improvement. Education reduces inappropriate prescribing. Case reviews improve learning. Audit and feedback improve prescribing habits. Guideline development standardizes care. Pharmacists lead educational sessions. Residents and fellows participate actively. Stewardship culture develops over time. Antimicrobial stewardship is patient safety. Prescription review is clinical reasoning in action. Pharmacists translate pharmacology into outcomes. Collaboration drives success. Data informs decisions. Communication sustains change. Every optimized prescription matters. Every intervention protects future therapy options. Stewardship today preserves antibiotics tomorrow. This brings us to the end of this educational session. But the conversation does not end here. Every optimized prescription saves a patient. Every stewardship decision protects the future. And every shared lesson strengthens global practice. If this video helped you think differently, if it added value to your clinical practice, take 1 second right now. Click the like button. It helps this education reach more clinicians worldwide. Share this video widely with colleagues. Share it with your ICU teams. Share it with pharmacists, microbiologists, and ID trainees. Someone else may need this knowledge today. Subscribe to the channel for more advanced antimicrobial stewardship content. And don't forget to hit the notification bell so you never miss upcoming clinical discussions and conference sessions. Most importantly, join the discussion below. Leave your thoughts in the comments section. Share your AMS challenges. Share your institutional experiences. Let's learn from each other, because stewardship is not one person's work. It is a global responsibility. I thank you for watching. Thank you for advancing antimicrobial stewardship. And I will see you in the next video.